Good afternoon, everyone, or good morning to those of you who are on the West Coast. Welcome to session 3 of the Health Center Preparedness and Response Forum on Workforce Readiness, hosted by the National Training and Technical Assistance Partners. Next slide. These are just a few housekeeping items. All participants are muted. Please use the Q&A box to ask any questions during the session. The webinar is being recorded. Materials will be emailed within a week. There will be an evaluation that will pop up at the close of the webinar, and it will also be included in the email to attendees. Please complete it. We love to receive your feedback. Next slide. So again, this is session 3 of the webinar series for the Health Center Emergency Preparedness and Response Forum. Today's session will focus on workforce readiness. The presenters will share strategies and promising practices to support clinic, staff, and community engagement preparedness, and recruitment retention, burnout prevention. Next slide. This forum is a collaboration between 11 different national training and technical assistance partners, or NTAPs. NTAPs are funded to provide free training and technical assistance to support health centers in a manner that increases patient safety and health outcomes to effectively serve health center populations. This training and technical assistance often takes the form of communities of practice, state, regional, national trainings, webinars, newsletters, toolkits, and fact sheets. We gathered together to address emergency preparedness because we are hearing and seeing the shared challenges across the various populations served by our partner health centers and lookalikes. Next slide. So the facilitators today are myself, Regina Brecker. I'm the project coordinator of training and technical assistance for the National Nurse-Led Care Consortium, and Renee Edwards, the director of training and technical assistance at Migrant Clinicians Network. Renee will be moderating the Q&A at the end of the session. Next slide. For today's agenda, Maricel Pagan-Santana will be discussing workforce readiness, including key drivers of readiness, core components of preparedness programs, and staff roles and training structures. Matt Beierschmidt will discuss workforce implementation, including competencies, recruitment and retention, and strategies for burnout. Next slide, please. We will be starting with workforce readiness. Next slide. So our first speaker is Maricel Pagan-Santana. She serves as Director of Environmental and Occupational Health of Migrant Clinicians Network in Puerto Rico, where she leads and coordinates MCN projects related to occupational health, disaster preparedness, and emergency response. She is also the organization's lead for the Caribbean office. Dr. Pagan-Santana provides technical assistance, training, and tool development for community health centers and the communities they serve to address disaster-related issues and health-related impacts. Next slide, and I'll pass it over to Maricel.
Thank you, Regina. Good morning and good afternoon to everybody, and thank you for being here and your interest in the topic. Today, we're going to cover some of the assessments to the readiness of workforce to support emergency preparedness. We're going to list some of the components for an employee readiness program and understand how to define and communicate those employee roles within the scope of could be a health center or your institution, to make sure that we're looking at not just the preparedness plan, but also how to make sure that our workforce is ready and able to respond and sustain those responses. Next slide. First of all, I want to make sure that we all understand that when we're talking about readiness, it's not just the infrastructure and operations of a health center, but also understanding that community readiness, those patients that we are addressing or the communities that were impacted, and also individual readiness like staff readiness are also part of the overall readiness of a health center. If we had a perfect emergency preparedness plan and response and recovery plan, but we are not ensuring that our staff members have also plans in place to make sure that they're able to comply or to respond to their work-related activities, we're not going to be successful. Also, we want to make sure that our patients are also involved, not only knowing how our health center is going to respond to emergencies, but also how they can contribute to that readiness and make sure that they're not creating a burden into the operations. Next slide. This is a framework that MCN, in collaboration with NAC, have worked on since 2023. It's understanding how health centers can navigate the changing weathers and all those emergencies that may come out of climate-related emergencies. And when I say we, the health center community, usually focus a lot on the one, which is the infrastructure and thinking about energy and water systems backups. But then we tend to fall short in partnerships with communities, clinical training and support, and mental health and well-being. Today, all you are here, so we're looking at improving that clinical training and support and make sure that we know the information and we are able to provide that training and assistant to workforce and to our operational systems. But I want to highlight that we also need to look at how to manage mental health and well-being within our clinical staff and support staff within operations, because that's also going to play a really big role when we have recurrent disasters or emergencies. Take a look at, for example, Florida being hit by back-to-back hurricanes in North Carolina 2 years ago, 1 year ago. Also Puerto Rico having a hurricane, earthquakes, and then COVID back to back also. So there's a lot of mental health and well-being support that needs to be structured within their workforce readiness components that we need to take a look at it. And again, we talk about community and patient readiness as well. So that partnerships and community relationship are essential to our overall emergency management preparedness. But today we're going to look at all clinical training and support and make sure that our staff is ready and able to respond to these emergencies. Next slide. There are core components to a workforce preparedness program. We want to make sure that we have comprehensive emergency procedures, and I know a lot of us already have that or are in a position to say that we're developing those. Just make sure that we know that we have to review them, and then they take in consideration how our workforce and overall human resources changes within our health center, and make sure that when we know who has a role and responsibility, we have a clear definition of that roles, and make sure that when any job category changes, it will have an implication into an emergency plan. So make sure that when we're reviewing the emergency procedure, we're just not looking at type of emergencies and infrastructure. Again, that we're looking at, have we added new roles within the organization? Do we have somebody who was in a role and at that moment was able to contribute to emergency response, but now is in a different role and maybe a little bit more occupied or busy or on a different workload that will not allow them to respond in the same way. So having that conversation and understanding the different roles and responsibilities will help out sustaining that emergency preparedness plan. Also, that we monitor our effective communication systems and make sure that we have reliable communication. Sometimes we think that we have set up a communication system or that we rely on something that might not be sustainable within different emergencies. So make sure that we're keeping up to date, that our technologies are up to date. And another core component is having role-based training and updates to make sure that we're not giving an overall preparedness training to comply with what we think about is emergency response, but also to understand if you have a specific role within your response plan, that you are training based on that role and not just providing an overall, this is how we prepare for emergencies piece type of training. Next slide. When we do role mapping and accountability, make sure that we are defining those roles and we have different categories. There roles for example, we have essential staff to carry out our operation through an emergency, and we may have non-essential staff. That non-essential staff may have a different type of job and role within an emergency, so making sure that we know where we're going to categorize that role. It also helps having different functional role groupings, which means that we're going to look at it, who falls within a specific grouping and what type of training and responsibilities they're going to go with around an emergency response. Take a look, for example, at outreach. It may be that today your outreach team's role and grouping may look like doing home visits or providing telehealth support or doing care coordination. But during an emergency, that outreach will look like identifying the type of supplies that a community need, or understanding the lack of power in specific communities and how to support medicine storage and other type of work. So understanding the groupings will help you identify specific roles and design specific trainings. Also, having accountability tools, like understanding who has which duties, instead of saying like every employee needs to be prepared and you have to read this, make sure that we know which person is accountable for specific role and actions within your plan, and make sure that everybody understands their role and their responsibilities. And again, there's a lot throughout this presentation about communication and training. We do need to have effective communication throughout our training to make sure that everybody's understanding their role within the emergency preparedness. Again, we tend to do a one-size-fits-all type of training. And sometimes we need to, that's the intent of this presentation, is to take a deeper look and understand that some of the employees may need a specific training. For example, there was a health center a couple of years ago that will create different groupings, and based on that, decided that some of the employees will need to have fit testing and um, respiratory protection training, because given a specific type of an emergency, those people were going to be exposed to either a specific health threat like COVID-19, and this was before COVID-19, but they were thinking more about exposure to chemical agents at that point. But those employees within that functional role had an additional fit testing training, and they were employees that at that moment were not clinical people who were in contact with patients. There were people who within an emergency role will be in contact with patients. So they needed extra training, fit testing, and that's the type of training that we're looking at. If you have some employees that will switch their role based on their emergency, we need to make sure that they're capable and have the training and resources to do that. Next slide. When we're talking about training, we need to make sure, and we know that not every individual learns the same way. That's one piece of it. The second piece of it is that not all content is made for the same type of training. So when we're looking at structuring or training processes, make sure that you have a training plan. This is not something that is going to get done in 1 month. This is something that you need to plan for. You have your emergency preparedness plan, you look at it, identify, maybe you do a training matrix and look at your core groups and decide which trainings are going to be being given this year to understand, to provide some resources to specific group functions. So you have to design a training plan, not just about your overall, again, I'm going to be really repetitive about this, not just to let them know and create awareness about your specific emergency response plan. But within that emergency response plan, there's different components. You want to make sure that they know how to respond to a specific type of emergencies, how to respond to a specific task within those emergencies, and that's going to create your training plan. You want to make sure that you have very deliberate methods. You'll have people who are more, they like more the role-playing type of trainings. They would like to be in person, and there's some people who enjoy having micro-learning. Micro-learning, which is small trainings at the time, helps with people who may have a little bit of higher workload, and you'll have, for example, sometimes clinical staff will say, I don't have time to sit out in a 1 hour training, but you can do micro trainings and make sure that you get them in a pace that that will get them the training that they require. And also understand the participation tracking. That's gonna say a lot within about the willingness and ability of your staff to respond, and even understand a lot of the pieces on wellness and mental health, because if you have staff that has been through emergencies and disasters recently, they might not be in the space to be part of your response team or a core team specifically with responsibilities. So that will help you a little bit on that sense, and also to create some accountability. You don't want somebody who is responsible for a big part of your operation to be absent for those trainings. You want to make sure that person is up to date, have the trainings, and have the knowledge, because if we're giving them the responsibility and the role, they need to be trained. But just make sure that you have a variety. Tabletops, you can do mobile trainings or distance training. You can do some kind, there's more complex training like virtual reality, but also a scenario training and even drills to make sure that everybody is able to respond accordingly. Next slide. The communication plans also part of your response plans. Again, these are plans within the plans. Understand that you have more than one channel of communication. Again, I'm gonna talk based on my experience and some of health centers that we have worked on here in Puerto Rico. But because of their experience with Joaquin Maria, you can ask them now how they're building the communication plans, and you'll see that they'll have more than one internet provider, more than one phone provider, because of how difficult communication was within that disaster. That doesn't mean that you have to do it that way, but just make sure that you know to which extent you're going to be able to communicate, and always have a second plan. If that fails, how are you going to communicate? There are even some experiences of teams that will be doing check-ins and will leave post-its in a specific place for people to know and for team members to know this happened, this person went that way because the internet or the systems that they had designed was not performing well during the emergency. Make sure that you have multi-channel communications. If one fails, the other one needs to be through a different channel. Do not repeat the same, let's say like, if your first channel is WhatsApp, which works through the internet, your second channel should not be through the same type of system. Should be a SMS or should be satellite. Um, Identifying clear roles on who's going to be sending alerts. Make sure that you're not sending conflicting information. Somebody's responsible for that communication. And that person's going to be understanding and be responsible in performing that, and make sure that every employee understands that they're going to receive the communication out of one specific person. And this is based morely in our the ICS system within the government response, is that we have a clear communication channel and processes to make sure that people are not self-deploying or giving multiple and conflicting instructions, or where to go, what to do, and how to respond. Again, make sure that we're providing different ways of accessibility, and understand the different literacy challenges to make sure that everybody's served. So we're not depending on just technology. There's some really good old best practices that we need to integrate in our current planning. And then make sure that we have employee support integration. Do it within those communication plans. How are we going to prevent burnout? How are we going to manage tools? Are we doing debriefings? Are we making sure we do check-ins with the or employees that are responding to that emergency, to make sure that we're giving them the space to process all the emergencies and cases that they're seeing throughout a specific event. Next slide. Important to think about launching and sustaining the program. This is just an overview how we will do it. It's a risk assessment. You'll have, other than your emergency preparedness plan, is to think about organizational weaknesses and where we're falling short in thinking what should we do in case or X or Y. So make sure that we look at the risk assessment from an operational standing point and from a human resources point. Take a look at, is your staff gonna be impacted the same way that your community is? For example, if you're in a rural area and we're talking about making sure the staff gets to the health center and there's flooding, are you able to communicate with staff before they're putting their life at risk trying to get to the health center? So understanding what your weaknesses organizations are. Also think about, we had a health center that their IT director was stranded in a specific location because of flooding, and that was the only person that was able to provide some kind of support for the electronic and medical records. So you don't want that to happen. You want to understand where you're lacking redundancy based on the capacity of your staff to make it to the point of getting to the health center, or even if they're not able to make it to the center, do they have the resources to support your operation from home or from the place that they're able to get to. Developing protocols and training. Again, we're talking about within your plan, you'll have a training plan to understand what needs to happen and what kind of recurrency. And it's always recommended to pilot the program. It's not just drills, but understand how we're gonna do it, how we're gonna get people engaged in that readiness, and make sure we can do it in different, do a deployment in different departments, and make sure that every department is covered within a specific time frame that we want to make sure the plan is ready. And then, like you do emergency response plans, a workforce development plan for emergency response and recovery and preparedness, you'll need to do reviews, drills, and evaluations, and make sure that you're getting feedback and that you're not losing uh, new information that can be impacting either positively or negatively the plan that you're doing. Next slide. And this is the part that for me is the one of the essential pieces is that we need to know, other than creating a plan, and that our infrastructure is ready, is our staff ready, willing, and able? This is a framework that is used in public health emergency preparedness, specifically for agencies, but it can be used in a health center, like the one that you are working in. You want to make sure that we're ready in terms of being available for action, service, or duty to response. You want to make that readiness is related to the training that you're providing. You have to be willing, and that's a lot with the mental health piece. Somebody needs to be predisposed to help and be part of that response. If you have somebody in a role and responsibility that is not willing, because of their previous experiences, then you're not going to be able to get that person within your plan. And then able is actually operational power. Do not give roles and responsibilities to people who do not have the power to perform those roles. Make sure that they have the skill, the expertise, the knowledge, and even the systemic systems to be able to do what you're wanting them to do within your response plans. Next slide. When we're saying ready, and think about organizational readiness for this, is having a roster. This is basically a checklist of stuff that you can have, or let's say items that you can use to see if your staff and emergency response team is ready. Having a roster with the skill expertise that are appropriate for emergency response. Do they have the training, or do they need the training? Having your rapid response team program, identifying staff we have a specific for specific emergencies, not the overall emergency plan, and even establish emergency operation centers. So this is a checklist that you can use to understand if you're ready to respond to an emergency, and also understand individually the number and percent of staff that have the skills. When you look at it for a perspective of, do we have a lot of staff that is undertrained or overtrained based on what we're looking at through um, our inventory of staff readiness. But those are just points that you can use. There are more things that you can get into that readiness and organization readiness, but think about how to look at your operation and understand people who have done before emergency response, who are able to or have experience now in doing emergency response, and who needs a little bit more training and have that in understanding. Next slide. Willing. This is more something that you will work from a type of employee survey, or understanding employee who want to be part of your emergency response. So even though it might fall within their responsibilities as an employee to be part of the response plan for a health center, you want to know and understand if they are willing to participate and they feel good about participating, and they have specific intentions, or for example, for staff that are not specifically designated within emergencies. Let's say staff that is part of your maintenance and housekeeping within the organization. Where do you see that staff working within an emergency and responding and recovery with communities in your operation? And if that start willing to or interested in participating in those activities, that will give you a sense of whether you need a specific wellness type of intervention and training, or are we okay and people will be um, I don't want to keep saying willing, but be up for the response piece of the plan. So make sure that it's not just about, hey, this is your role, but are you willing to do that? Are you willing to 10 hours after an emergency leave your family and come here and be our first group of staff members that are in our center to respond? Are you willing to, now that you are maybe an admin support for a medical director, switch to be the person who is receiving patients in the front and take over supplies and community needs? So understanding that willingness and understanding the well-being will give you a sense of, yeah, we have a plan and people are ready and excited to be serving during those moments. Next slide. Enable is really just about making sure that our infrastructure, competencies, skills, training, and also systems and tools are defined, ready, and available. We need to make sure that, again, we take a look at the person who has been completed training, persons who need a little bit more training, and even having a specific numbers of responders based on the type of need that you will expect based on an emergency, and have that understanding as well. You may be able, as a community health center, to respond to your community in a different levels of an emergency, but there might be a bigger emergency that you're not capable or don't have the structure to be responded. So understanding where your level of response is based on the trained people that you have in your staff and the people who are willing to serve as responders, it's gonna give you an understanding of the capacity of your health center to respond to those emergencies. Next slide. Just closing in some of the preparedness pieces, make sure that you have design and communicated roles and everybody employee knows exactly what they are supposed to do within that emergency plan and how they're gonna respond it. Providing recurring training, you're giving the employee a role and responsibility, make sure that they have the training to be able to perform. Make sure that we have dynamic programs and we're not stuck to the same program. We don't want people skipping a PowerPoint and make sure that they're complying with the final quiz and it's the same quiz each year and we're not making sure that there's a complete understanding and engagement. You will have to work in your staff engagement and to be part of the plan, to feel like they're involved and they're responsible for that to be a success. And then make sure that you have the support resources. If you notice that we have systems that may collapse, make sure that we have resources in if physical aid and it's not all depending on one specific system. Like we talk with communications, also have the resources in a way that everybody can access them and it's not something depending of sitting in your laptop and opening up. We have to have that available for employees. Next slide. Other considerations, like I said, this is more bigger than just the operational functioning of the health center. Make sure that you have individual and family planning within your staff and patients. If you are in a area that has a seasonal risk to a specific disaster, that might be wildfires, hurricanes, make sure that you are talking to your staff members about family planning and what they're going to be doing if something like a hurricane happens. That will make sure that that staff member, if their family is prepared, they're not going to be thinking about needing to go home right before a storm versus knowing that their family is in good care and they're able to support your emergency response plan. Same with patients. Make sure that your patient understand how they're going to manage emergencies and how the health center is going to be operating based on that emergency. So you don't have the day before a hurricane, a lot of patients asking about their refills for prescriptions or even losing their medicine right away. So working with individual and family planning within staff and patients are going to make your operational plan stronger. Also, community planning and mobilization helps a lot with reducing the burden of the operations in the health center. We want to make sure that those first 48 hours, the health center is focusing on the most traumatic injuries and illness rather than things that can be prevented. You want to make sure that you're taking in a response and first aid type of things rather than trying to find a medicine that got lost or a refill that wasn't filled at the exact time. That kind of topics that can be preventable. avoid fatigue and burnout, understand what your level of tolerance of your staff is based on the operational hours that you're doing and based on the impact that they're having within their own homes and community areas. And also think about language both for patients and staff members in terms of your planning and response. We want emergency preparedness plans in the language that the person is dominating. The training also should be in the first language of that person. If you have staff that comes from diverse backgrounds, make sure that we're considering cultural changes in those trainings to make them more effective. And again, let's avoid fatigue and burnout and understand the well-being needs of your staff within the framework of preparedness, recovery, and response, because we know that it will take a long time to recover from major disasters and want to make sure that we have a plan on how we're going to manage that fatigue. And I think that's it on my end. We do have our last slide, which is an invitation for you all to access our webpage and connect to our resources. We do talk about a lot of our community mobilization and have a couple of tools related to that if you're interested. Thank you. And we're in Substack.
Thank you so much, Marisol. That was such a great presentation. And we're going to hold any questions we might have until the end. So our next speaker is Matt Beierschmidt. Matt has over 20 years of experience in nonprofit management and program management across the healthcare, education, and social services sectors. He currently serves as Assistant Director of Training and Technical Assistance at the National Nurse-Led Care Consortium, NNCC, where he leads initiatives supported by federal, state, and community partners to strengthen NNCC TTA activities and NNCC's overall mission. Matt oversees the HRSA-funded National Training and Technical Assistance Partnership and Project Work Plan and provides strategic consultation to NNCC's senior management. He designs, co-designs, and delivers web-based and in-person training to improve access and outcomes with support from his NTAP team. Across Matt's current and past experience, he has always believed that strong systems and partnerships are essential to improving access and outcomes for underserved communities. Matt holds a Bachelor of Arts from Rutgers University and a Master of Public Policy from Temple University. I'll pass it over to you, Matt.
Thanks, Regina. I'm going to hop right in. So MCM just walked us through how to assess workforce readiness, infrastructure, partnerships, willingness, and deployment capacity. NNC's focus this presentation is going to be on what comes next. How do you operationalize readiness at the staff level? Because having a plan is not the same as being a prepared workforce. Prepared staff doesn't happen by accident. They are trained, supported, and structured, and this is where our competencies come in. So I'm going to explain those later on. So talking about workforce supports and plans and training. Emergency plans often sit in binders or in share drives, but during activation, staff aren't looking for a certain document. They're looking for clarity. Every staff member, clinical and non-clinical, should know what is my role, how do I report, who do I report to, how do I communicate, what is expected of me. Clarity reduces the chaos, and reduced chaos reduces work stress and burnout during emergencies. And when we talk about training, we often think about compliance, but preparedness training is also part of workforce protections. When staff understand expectations ahead of time, they feel more confident. They experience less panic during activation, and they're more willing to respond. In today's environment, staff are overwhelmed with required trainings, as we all know. Competencies help health centers. The competencies help health centers protect preparedness time by defining what is essential. They ensure that the front desk, medical assistants, nurses, providers, and administrators all share a consistent baseline understanding of emergency strategies, and competencies bring structure to that otherwise overwhelmed feeling. So we have the all hazards competencies that we have developed, and the goal of the competencies was to improve health center emergency and disaster preparedness and response recovery, so they may continue to care for their patients and support integrated community health response. And the outcome, all health center staff achieve basic level of competencies, perform assigned responses, and recovery roles across disciplines and skill levels to support their CHC and larger community. Why the emergency competencies? Because how the companies help health centers, again, they reduce local training time and align roles across disciplines, establish a consistent preparedness baseline, and protect preparedness learning and competing priorities. So this is the current version of our competencies we just recently updated. NNC has developed 4 core competencies to strengthen workforce readiness. They move from foundational knowledge to applied expectations. Notice that this is not just about emergency operations. It includes staff safety and patient well-being because workforce readiness and continuity of care are inseparable. And this is kind of the bullet slide over here. The competencies cover basic emergency management. They have roles, expectations in emergency, principles of communication. The 4th competency, staff risk and reduction and stress management, and maintaining patient well-being. And these apply to all staff, clinical and non-clinical. Again, this is just a quick run through what these competencies are, and then I'm explaining later. So first, we have demonstrate knowledge of the principles of emergency management. We have competency 2, role expectations in emergencies, demonstrate knowledge of unexpected roles in organizational response plans activated during a disaster or public health emergency. We have principles of communication. We demonstrate knowledge of general communication principles and organization-specific communication policies and procedures to be implemented during disaster or public health emergency. We have the competency of staff risk reduction and stress management. We demonstrate knowledge of personal health and safety measures that can be implemented in a disaster or public health emergency. Maintain patient well-being. This is demonstrate knowledge of how one's organization will support the physical and mental health of its patients before, during, and after a disaster or public health emergency. And the 2 competencies that directly support workforce stability, a workforce discussion today. The first is roles and expectations. If staff do know their role during activation, hesitation, and duplication error, this reduces hesitation and duplication error during activation. And second is risk reduction and stress management. Staff need to understand personal safety measures, stress reactions, and how their organization supports them. When staff feel protected, they're more willing to serve and respond. Competencies alone are not enough. They have been translated into practice. Our work readiness approach is intentionally layered. We begin with the asynchronous learning modules to establish a shared foundational understanding across all staff. That knowledge is then reinforced through structure, in-person facilitation guides, that encourage discussion-based application with teams. Critically, this learning is not abstract. It's integrated with your health center's own emergency operations plan, so staff can apply concepts to their real procedures and not hypothetical ones. Finally, we emphasize doing tabletop exercises and scenario-based practices. We do provide those because preparedness is not built through review, it is built through rehearsal. When teams practice together before a real event occurs, readiness becomes a muscle memory rather than theory. Building workforce and readiness intentionally. Organizational commitment is the foundation of workforce readiness and a core component of health center emergency management and continuity operations. Effective preparedness begins with clearly defined roles and responsibilities, followed by community competency-based training that ensures staff understand how to communicate, coordinate, and respond during emergency. Sustained readiness requires an ongoing cycle of planning, training, testing, and assessment. Regular exercises, structured evaluation, and improved planning and health center maintain readiness. Improved planning help health centers maintain readiness, keep emergency plans current, and meet federal expectations, including the CMS Emergency Preparedness Rule. When health centers integrate assessment, competency development, and continuous practice, they strengthen the regulatory compliance, operational resilience, and continuity of patient care before, during, and after a public health emergency. Workforce readiness is measurable, competency development is achievable, and sustained preparedness results from the deliberate and intentional organizational commitment. Up to this point, we focus on readiness and readiness assessment and competencies, but readiness is not sustainable without workforce stability. Recruitment and retention are among emergency preparedness infrastructures. Recruitment supports ready, retention protects willing, and professional development builds able. Health centers that intentionally recruit bilingual staff, community health workers, individuals with strong community trust are strengthening the capacity before a disaster occurs. Embedding emergency role clarity into onboarding ensures that preparedness expectations are clear from day one, and retention strategies like career ladders tied to all hazards competencies reinforce the emergency preparedness as part of professional growth and not just an add-on task. Preparedness must be visible at the leadership level when leadership consistently provides emergency readiness and signals that this work matters. Burnout and prevention protects readiness. When we think about workforce readiness, we often think about training, but burnout prevention is just as critical. In the Ready and Willing and Able framework, burnouts most affects willing. It feels If staff feels unsupported during an emergency, future participation declines that directly weakens emergency response capacity. Promising practices we're seeing include structured debriefs after tabletop. Burnout prevention protects readiness. Burnout prevention is preparedness strategy. Psychological safety during and after events, structured debriefs following exercise and activations, and patient-directed supervision, peer support models, and recovery time after response efforts. From competencies to culture, promising practice, health centers are strengthening workforce readiness by cross-training staff for surge flexibility, using roll cards and quick reference tools, integrating CHWs in emergency response plans, and conducting exercises with structured learning loops, and succession planning for emergency leadership. And that's the end of my presentation. But I do want to preface or say that the modules I spoke about earlier, they're in the final stages of pilot mode and should be live for use. So I'm talking about the emergency preparedness LMS that we have, where you can do the the in-person exercises and the tabletop guides. That will be available within the next month. So please keep an eye out for that, and we will email all registrants a link to the LMS that you can walk through the modules yourself anytime you at your own pace. So keep an eye out for that, and thank you again.
Okay, so we can want to thank you all for participating today. We have at least one question in the Q&A right now. We've got some resources as well that will be clickable when you get the slide deck. And so let's first take a moment here and answer the question that we've got here. This says, I greatly appreciate the information from a public health systems perspective, but as a community public population health nurse who independently practices in a very rural area located in the northernmost part of the county where they live, which is the main community is 45 minutes away, and that's an hour. So to any kind of hospital for this person. Along with an EMS system that has difficulty staffing. EMTs are on call 24/7, 365 days a year. To get to the question, it's very worrisome to see the erosion occurring in our system, let alone preparing for emergencies in a rural community. How can nursing leaders harness more local more local emergency trained community members as volunteers to be available to respond when an emergency happens, especially for those who aren't in official roles. So do any of you have experience really trying to get community members or like the medical corps in your area to kind of get some local folks involved?
Yes. So that's where the community mobilization piece enters into play. Definitely, we have a lot of experience with rural areas in Puerto Rico that were isolated during the emergencies. We had really sad stories about community members not being able to give CPR, for example, for a member of the community where they were isolated, and sadly they lost that person of the community based on that situation. So recently, over the last 5 years, we have worked a lot with health centers in rural areas to develop the capacity of the community, identifying resources. And when I mean resources, it's not just monetary and physical resources, but also understanding what the community is able to do. We may not be able to save everything, but taking a look at who can help out in the shelter, who can able to take care of the children, to give. We had even identified retired emergency staff that were part of the community and that are able and willing to help. So the same framework about willingness and readiness and resources applies to your community. And if you do a community mobilization piece, I understand the rural piece and isolated component of it, but let's think about the health center and your service area. And you may have a specific community that's just really distant, like 1 hour away, like you say, 45 minutes away. That's the community that I want to do community mobilization with. That's the community I want to know their leaders and make sure that I link them in my emergency response plan, because those are the ones that are going to need my immediate help. Those are the ones that I want to make sure that I know what to do if they're isolated. That specific community even talk about creating a space and make sure that terrain was able to receive helicopters, because they were not going to be able to go to the health center, but the health center, they had a helipad. and they were able to receive some of the government help. So there's a lot of the community mobilization that having that information and exchange with communities will let you into helping out in an organizational and interagency collaboration to make sure that the supplies get delivered and the help. Within the clinical response piece, the ability to respond, even the mental health supports, is the same. You can create your community mobilization plan, make sure the community is invested, and make sure that your leaders are able, willing, and ready to respond. So it's the same framework. Just make sure that you're having that conversation with the community and understand your scope of work and your capacity. It might not be the perfect response plans, but you may have something. And that something is going to do wonders when an agency or another organization comes in to help, because you're going to have the information and you're going to have the operational system within your community. It helps a lot. It's not going to be perfect, but it does organize in your community and do that piece of doing even a SWOT analysis and historically understanding what happens during emergencies in that community will help you understand what you're able to do and what you just don't have the resources to do. And then with that understanding, that's where you start looking for more resources.
Does anyone have any other new questions that you'd like to drop in the chat, to drop in the Q&A box? And I'm going to step back to a question that someone asked earlier, and I gave my thoughts on it, but you all may have something more you'd like to say. And Jorge was asking, what they've witnessed lately has been that people are suffering from mental health issues that they are not may not be aware of, and maybe masking their competencies due to limited oversight practices that haven't allowed proper post-action review or an accurate situation report that is correlated with contingency planning or how collaborative planning looks as emerging findings bring about mandatory training, safety standards, or ensuing changes to research incumbent workforce development. And so my thoughts were, having a patient, not a coworker who I needed to switch the kind of work that they were doing because of mental health issues that they had, and give them a more passive role. And I'm not sure if that was exactly what you were getting at, Jorge. So if you all have like some different perspectives or take that question in a different way, I just wanted to say it out loud here.
I'm going to take us. Oh, Matt, there you go. So you're unmuting, so maybe you do.
No, I was just going to comment that I definitely agree with Jose, and I was thinking that one thing I want to share is that that's why even what makes webinars like today and training like this even more important. So we are aware of the staff's competencies and capacities to respond and provide a place in the emergency planning. And but this, like, as mandatory trainings come up and we have standards, we need to be able to train properly, so we know our staff, not just like train them with what their role is going to be, but also what their capacity is, what they feel more comfortable with. I see another comment down here about how um, some staff feel more active in a passive role, or more, and there are roles in the in the response plan for those people to take on. Maybe it's like a communications role, like in the background, or overseeing some other administrative task, or being an on-site person. But there are roles within probably all emergency plans where different people's different comfort levels can be fit into their plan. But again, it needs to be a conversation you have with your staff, and maybe even a one-on-one, to ensure that this person feels comfortable with this role. And if not, move on to something else. Or if they don't feel comfortable and get no one else to fill that role right at the moment, maybe talk with them, give them a little further training on top of that. And if they still don't feel comfortable, then you can take it from there. But I think that just making sure that there's consistent trainings around this, and making sure that everybody not only knows the training, but feels comfortable in the role. You can train for a role but not feel comfortable in it, so make sure that they feel comfortable in that role as well.
Yeah. And the redundancy piece as well. Like you may have somebody who's trained in a specific piece of it in the first, let's say like the first hurricane, that person was able to respond. It was really good at it. But in the second one, their family member was impacted. and at this time is not longer able to do it. So that person needs to be relocated, reassigned roles in another space. And you need somebody who comes and fill that position. So having redundancy, understanding that every situation is a new situation, and having the framework to be able to respond to that flow and flexibility within the emergency preparedness. Also, you'll have persons who will get delay burnout within the emergency response. So if you have the same team working the same stuff for more than a week, you have to make sure that you're still switching some of the rules to avoid that type of situation.
And yeah, and we mentioned, I don't know if I mentioned in mine, but I think I did. I might have skipped it because I didn't have my script, my speaker notes when I came back online. But cross training is really important too. Cross training like staff members to do multiple roles. We're already talking about like not getting overwhelmed, but now we're talking to cross train people in multiple roles. But it's good for the people have familiarity around other roles that they're comfortable with. So, like I said, like what if someone just had a newborn baby, like, within the last time you guys ran this and now they're not available, so ensuring that people can easily transition into roles that they've been trained on already. And like, so cross training is also a really good way to avoid gaps and making sure that, you know, whatever the emergency is, that there's somebody in that position that can fill in that role.
Thank you all. There's another question. It says, is anyone familiar with the current initiatives in place to help organizations or FEMA help prepare personnel, evaluate our old practices deemed best practice? How can we move forward if we're not being informed about sit reps or how emerging findings are integrating necessary training to help prepare us for what is happening due to other emerging concerns?
Do you have an answer for that, Marcel?
Not particularly. I think your people who are heading up your emergency preparedness plans, we need to find capacity building opportunities for them. They should know at least the updates on the ICS. I'm sorry, I'm missing the complete name. I'm just assuming that somebody here knows that what I'm meaning. Your communication and integrated communication and management system for emergencies that we use as a framework in government. Those are trainings that are available. FEMA has their training. So make sure that at least your point of contact, it has that basic training. And then if we need to do capacity building, if you need to look for sending that person to having training within a university or a specific provider, I will not say that it's a bad idea, but I will encourage you to create capacity building within your organization rather than looking for somebody who comes in and create a plan for you. I have seen that happen. I get to a health center and I see a plan that is not exactly responded to specific community needs because we just went and hired somebody to make that plan for us and do the assessment for us. So I know it takes time and we have to allocate resources, funding, and time to create our own emergency planning. But just take one step at a time and trying to do it and create the capacity within the health center. So look at who's going to be responsible. If it's your security person, or if you have a specific emergency preparedness, or even the health and safety person, to get capacitated, and that person will come up to your staff with the best practices. Bringing somebody from outside might be helpful to give you a new look and evaluate and maybe an audit on your plan, but it's not a good idea to create a plan with somebody who's not within the organization. At least that's an opinion, in terms of how we create stuff.
And I think that you're saying resources too. I don't know if you mean like if there's any outside resources as far as like funding or planning, but that could be what you're asking as well. I'm sure I can't think of offhand, but we do have a resource slide at the end of this, so we will share out that, and then if anybody we take these questions and we will look at the answers later too, and maybe if we can provide further resources for you on the other end, we'll send it out for you. But that's a good question, and we can probably
And
answer
I
that in a
see
follow-up
I
email.
see that Jorge is chatting also and spending a little bit of his thinking with behind the question. So or thank you, national management system and incident command system. Thank you. So Our national frameworks actually depend on community mobilization. And this is something that we are really bad at communicating as the government is really bad at communicating that they're not the sole and primary stakeholder within emergency response. And we're thought that FEMA and the emergency management departments are the ones who are supposed to lead the disaster response. They do have skills and training, but when you see our national framework, it also talks about bottom-up approach. It means that you have to get your community organized and you have to let them know where to respond. And this is something that we do really poorly. We don't talk about that as much as we should. And we focus on the emergency management department capacity to respond to a whole wide area, county, state, whatever we want to call it. But then when you look at the framework that they use, it says, well, we cannot do it all. We don't know it all. So we need communities to be prepared. So working on that bottom-up approach and understanding your capacity. And then, yes, we can reach out to FEMA to have some trainings, or even there's some CDC trainings that you can provide to the community, CPR, one of them, emergency management, and talk about flooding. But the capacity of a government to respond to every disaster in a way that applies to your community is really difficult if your community is not prepared. The same goes with the center. We're not going to be able to help you if you don't have a plan that is located hyper local to your operation and location.
That's
All
it for the
right.
question.
Yeah. I don't see any more questions. We are at time now. So with that, I think we can close it out unless something else has popped up, but I don't see. Let me see if there's anything else. Oh, this is it, guys, for your questions.
Thank you.
Thanks, everyone.